So I'm really, really excited to be introducing this next session. Even though our goal for this conference was to take a bit of a break from, coronavirus news and current events, we had the opportunity to include our next panelist, Dr. Amesh Adalja, who's a world expert on infectious disease. And since this is still, the most important thing happening in the world right now, we thought we would devote one session of this event to getting some insights on the pandemic from someone who is literally on the front lines and extremely knowledgeable about this. Dr. Adalja he's a physician specializing in infectious disease and emergency medicine. So he's someone who's actually treating COVID-19 patients in the hospital. He's a senior scholar with the Center for Health Security at Johns Hopkins University. So he's been studying and writing about the risk of infectious disease outbreaks literally for years. You've probably seen him on TV. He's been interviewed as an expert on every major news show, sometimes multiple times per day since this pandemic began. He's quoted in news stories from all the major outlets. And he's also someone who's very familiar to the OCON community. He's a longtime objectivist. He's been a frequent speaker at OCON on infectious disease, vaccination, other topics related to his expertise. He's been a student in the OAC. He's someone who can apply his knowledge of objectivism to his field of expertise. From where I sit, he's been a really calm and deeply knowledgeable voice of reason throughout this whole coronavirus situation. So I'm really excited that we can have Amesh with us today. Now, from what I just said, you can imagine that he's extremely busy. He could get a media request at any time. He's due at the hospital later today. He's literally on call right now. So what we're going to do for this session is we're going to start with a video interview with Amesh that was recorded just 2 days ago. Onkar Ghate recorded an interview with Amesh on Thursday evening. So we're going to start by playing the recording of that interview, which will run for about half an hour. And then Amesh and Onkar will both join us live, and we'll have a live Q&A session for about half an hour.
I have the privilege of talking to a real expert on infectious disease and pandemic preparedness. I think someone familiar to a lot of you in the audience, Dr. Amesh Adalja. So welcome, and thanks for taking the time to answer some of my questions, and I think questions that a lot of people have.
Yeah, sure. Thanks for having me.
I think it would be a good place to start is if you can recap where you think we are in the pandemic. And I'm sure you've seen stories, I've seen stories about some of the experts are saying, like, we're in the second inning of this pandemic. So how do you think about it, where we are and what the trajectory is?
We're sort of at the end of the beginning. This is going to be a virus that stays with us for the foreseeable future until there's a vaccine, because it's something that transmits efficiently between humans, and it's become what we call endemic. So it's not going to go anywhere. And the question now becomes, how do we cope with this virus going forward? How do we adjust our risk preference? And how do we get it better when it comes through successive waves as it intensifies and de-intensifies? Now this is a time that we're really going to see how well we can cope with it, because we just saw the first forays of it, and I think we did horribly dealing with it in its first appearance. And now it's going to establish itself, and it may intensify in the winter, and I think that's where we're really going to be tested again and again until there's a vaccine.
So do you think of it, it's often put as there's the issue of mitigation and eradication or some equivalent of the virus, and that eradication is really no longer on the table? And do you think if that's right, that's true for all the countries, including, so I know some of the island countries like New Zealand, it's easier to try to seal your borders and then eradicate, but obviously they have a lot of trade and a lot of interaction with the rest of the world. So do you think sort of worldwide, it's everywhere, it's the issues mitigation now, not eradication?
Yeah, I do, because this is a virus that's established itself in the human population. So the question is, when you have a virus that has made itself basically part of the infectious diseases that humans deal with on a day-to-day basis, how do you actually get it out of the population? And the fact is, it's very, very hard to do that. We've only eradicated one disease off the planet, and that was smallpox. And it had very different characteristics. It wasn't spread. It was something that when you got infected with, that you could easily identify people. It didn't spread during its incubation period. We had a really effective vaccine. None of that applies to this coronavirus. I do think that if you had a vaccine, then you can start thinking about that. But right now, this is something that we have to think about mitigating and learning to live with rather than trying to eradicate it. This is something that you've seen some countries get cases down very low, but that's only because of really aggressive social distancing that they put into place. And the fact of the matter is, when you see any kind of reanimation, when people start to socially interact, they're going to spread the virus. And a country like New Zealand, because it's an island, can do a good job of getting it off the island. But remember, their economy is almost completely dependent upon tourism. So it's not something that they can keep out forever. It's just getting themselves in a better place so they can handle the cases that they do get in the future.
Okay, so now I want to ask, that's really helpful. I want to ask a few questions sort of about your current thinking about the nature of the virus. And the first is about how contagious it is. And if it's right, as I think more evidence is coming out, and this is, you had said this very early on from what I remember, that we likely had cases, for instance, in the US, but other parts of the world outside of China, earlier than what people were originally saying. So maybe early January in the US. If that's right, what does it tell us about how contagious is it? Like, would you have expected to see more cases than there are in the US and other parts of the world if the virus was there earlier? So how are you thinking now about the level of contagiousness of the virus?
So there's two things that factor into the contagiousness. First, how is it spread? It's spread through respiratory droplets, coughs and sneezes, and surfaces that those coughs and sneezes land on. So that's a fairly easy way for a virus to get to people. So in terms of how different viruses spread between people, that's a really advantageous way to spread if you're a virus. The other thing is this is a novel coronavirus. So there is no population level immunity to it, which means everybody is susceptible to it if they get exposed to it. So you put those two things together, and that's where you get a very contagious virus, where maybe somebody infects 2 or 3 more people when they're infected. The thing is, when you have a virus like that, you have to, and you have a spectrum of illness. Most cases are mild. Some people don't even know that they're ill. And this thing appeared in China maybe in mid-November probably at the absolute latest. And it wasn't noticed, wasn't reported to the World Health Organization until December 31. So you've got this huge head start of a virus that has mild symptoms and is completely indistinguishable from other common colds and influenza. And the logical conclusion is that this was everywhere before you actually even noticed it. And that's been the case with many of these respiratory viruses. It took some time to figure that out. And now we're seeing, for example, in France, that there was an individual who was diagnosed in December 27th, had never traveled outside of France in the time period that he would have been exposed. So it clearly was in France around Christmas time. So you know that this had been in many different places. It just takes a while for a virus to get hold and really start to spread at a big enough amount that you actually notice it. It's kind of an exponential slope that it goes to. It just takes a while for those cases to accrue enough to be able to see sparks flying off into different countries. But I do suspect we will see cases that occurred in the United States definitely in early January, maybe even in December. And this is an active area of research right now, trying to go back and look at these cases that got misdiagnosed as the flu or something else. And we're not very good at diagnosing viral illnesses, so it would not be surprising that we had cases in December.
So do you think then, if that is true, there was never really a possibility of it being contained? It was always going to be, it's already spread enough when we're noticing it, identifying it, and trying to take countermeasures, that it was really always, we're going to have to learn to live with this and mitigate it. There was no possibility of containment and eradication.
Exactly. So I was saying that back in January, and I was being called a defeatist. But I was just looking at the biological characteristics of the virus, saying there's no way. We need to stop wasting time with Air Force-based quarantines, travel screening, travel bans, directing what are really scarce public health resources away from what we needed to do, which was scale up diagnostic testing, get hospitals ready, public health communication, personal protective equipment. We had to get ready because this was coming, whether we liked it or not, no matter how much emphasis was placed on trying to label this as a disease that was in China and that it was only a couple cases here and it's going to be 0 soon. That was kind of magical thinking, if you know anything about viruses.
Okay, so that's a little bit I wanted to ask about its contagiousness. Now, I've also read some things, and I want to get an expert's take on this, that your exposure to it, what it's sometimes put, I think, as the viral load that you get when you're first exposed to it, that makes a difference on how severe the resulting illness will be when you're exposed. And do you think there's any evidence for that kind of view, that your initial exposure, the load of it, so the amount you're exposed to, makes a difference?
So in many infectious diseases, the infecting load or the infectious dose does play a role, meaning that if it's too much, it can overwhelm the immune system and overwhelm your body's ability to cope with it. I don't think it makes much of a difference in day-to-day life for an average person getting it, but clearly there have been some healthcare worker deaths that have been pretty fulminant, young people that don't have medical problems who may have been doing a medical procedure and got sprayed directly with a lot of viral particles. And I think that's something we're trying to understand. But in general, yes, that does happen with other infectious diseases. And it wouldn't be surprising to see that that's the case with some of the fulminant cases that have occurred in healthcare workers.
Yeah, because I think that's one of the things that has really scared people about the number of healthcare workers who seem to have really adverse health effects once they get the virus. And so if thinking of that in the context of what they call the case fatality rate, and that's an average of a lot of different cases, so how both sort of as researching, and I know you're also a practicing physician, when you're thinking of the case fatality rate and the range, and the two things they talk about, but I think there's a correlation between these two. So how old you are matters, and it seems to be a disease that really affects the old, like a lot of diseases do, that you have adverse health outcomes. But then also if you have existing conditions, and certain of existing health conditions seem to make people particularly susceptible. Now it often goes together, that how old you are and that you have health conditions. So in thinking, a person thinking like, what's my risk here? And you've talked about, we have to learn to live with this and think about mitigation strategies, but also going on with your life. So how people, based on both the age ranges and their health ranges, how right now do you think people should be thinking about how at risk they are?
So there's not going to be a one-size-fits-all answer or some kind of black and white prescriptive thing that I can tell people. What I would say is that you have to look and see, how old are you? What other medical conditions do you have? And then think about what the activity you're doing is going to be, and how likely you are to be exposed to the virus. And are there ways to kind of decrease that by social distancing if you're doing the activity, or being really meticulous with hand washing? And then you have to kind of think about it. So if you're an 80-year-old, obviously if you get sick and ill, you have a very high rate of hospitalization and a very high chance of dying, maybe 15% if you end up in a hospital if you're in that age range. But if you're 19 and you don't take care of your grandmother, or you don't worry about transmitting it to other people, you probably, even if you get it, you may not even notice that you get it. You're probably likely to have something like a common cold. And I think that's the challenge with this, is that it has such a different disparity in the way it affects different age groups and demographic groups, that it makes it very hard to convince a 19-year-old that this is important when they think of it as just a common cold, and an 80-year-old who really thinks of it as a death sentence if they get it. And I don't think that there's going to be an easy way to come up with this answer. It's a horrible choice that most people are going to face, because it is true that many people do have contacts that are in that group of high-risk individuals, maybe a parent, a grandparent, or maybe they work somewhere, or an immunosuppressed patient. That's going to be something that's hard to do. So I think that you have to kind of look at the whole context of your life and think about what's essential, what's not essential, how risky is this activity, and then make a choice. And I think it's going to be different for every person. And it's not going to be something that we can say, this is absolutely off limits, this is not off limits. It's really going to depend on what we do, because all of this social distancing that we did was really to preserve hospital capacity. And now that seems to be largely solved, hopefully largely solved. And now it's going to really come down to the individual's risk preference and how to go forward with it. And I think we've not had to deal with this for a long, long time. We've had the luxury of not living in a place where there are infectious diseases around because of vaccines. And I think this is the first time people have dealt with this, probably in half a century.
And do you think anything so obviously scientists, doctors, researchers are learning more as they have more experience with the virus and are studying it. Has anything changed in terms of people's thinking about what the risk factors are or aren't? Like they thought maybe diabetes was, but now maybe it isn't, or anything like that has changed from early on to now?
No, it's basically been the same. It's age and then other risk factors, things like diabetes, asthma, any kind of lung disease, immunosuppressing conditions, obesity. That tends to be what we see. And they all go together. And there will be studies that'll start to tease these things apart and see which has the bigger contribution and which is kind of a correlation, but not a causation. But I do think it's the same types of risk factors that we see, for example, in an influenza for the most part. There are some exceptions, but this is what we expect to see when you have a respiratory virus. These are the people you expect to have a severe course, and it's following that pattern.
I see. So that's a little bit on asking about some of the current characteristics and knowledge about the virus, how contagious it is, the fatality rates. In studying this, so obviously there's been a lot of discussion about the models. It seemed, so one of the famous ones is the Imperial College model that supposedly changed both kind of the behavior and course of action in the UK and in the US as well. And so you study infectious diseases, you study pandemics. What is the role of models in the studying of these things, and how much are they that you're trying to understand a past pandemic and you're modeling it, and how much do they have predictive value? So that's one of the things I'm interested in.
This is a very controversial topic in our field, and there are people who swear by models and there are people who won't go near models, and there's always this dictum that all models are wrong, some of them are useful. And that's how I think about them, that they have their thought experiments. They're what could happen. And a model is really based upon the assumptions that are put into them. And some of those assumptions can be off. So for example, if you look at many of the models that were off, the reason most likely that they were off is that they were overestimating the hospitalization rate because they were taking data from China, which was what we call severity biased, meaning that they had a bias because these were individuals who were coming to be seen at the hospital. They weren't accounting for the asymptomatic infections. And then you say, oh, it's 20% of people that are going to be hospitalized, and we're thinking 60% of the population is going to get infected. In my town has 100,000 people in it. That's a really big number versus if it's maybe only 5% that are getting hospitalized. And then that changes the whole planning assumption. And that's the important thing, is that models have to evolve when you actually have real world data. They're a reflection of reality, not a substitute for reality. And you have to go back and change the assumptions when you actually get the data to plug them back in. And that's when they change, when you do that. The other thing is that they give you a range of assumptions. Modelers are often agnostic about all of it. They just kind of give you different ranges. And often what ends up happening is policymakers and the media will pick the worst case scenario and actually mention that one, and not realize if you look at the confidence interval that it drops very low, and it's not necessarily reflective of what the model is actually saying. And I think that that's one of the big lessons of this. So if you go back to Ebola in 2014, some of those models are predicting 3 million deaths from Ebola, and everybody laughed at that because we knew that they were wrong. In this pandemic, because I think people were very panicked in a different way, they took the models, a lot of them at face value, and some of the modelers actually became celebrities on television all the time talking about it. And I think the models are important tools. I think that they help us understand things, but you can't use them as a reflection of reality or a prediction that's like a crystal ball and take them as basically infallible, because they're just ways of thinking about things. And it's taking a very complicated topic, how an infectious disease spreads through a population, and trying to fit it to equations. And the equations are never going to be as complex as what's actually going on. So you just have to assume the models are going to be wrong and allow it to kind of gauge the way you think about what might happen, but never really allow them to substitute for what you're actually seeing on the ground. Because they were saying, for example, when I was working in Pittsburgh, and they're saying we're going to get really bad this weekend. It's a peak, but the peak, I'm looking around in the hospital saying I don't see anything here. So it's like a weatherman. Eventually, when they're wrong and it's not raining, when they say it's raining, you have to start thinking about how valuable was that model and what were the assumptions that got it wrong. And
so you brought up Ebola, and I've read a little bit about that the models were way high. Is there a tendency that when they're in error, that there tend to be overestimates than underestimates? And is that part of in terms of modeling it and getting a range of scenarios, you want to get what if everything went wrong, this would be the worst case? Not saying that that's what's going to happen, but it's useful to think of worst case scenarios?
Yeah, when it comes to pandemics and infectious disease epidemics and outbreaks, you want to be biased to over prepare. You want it to be something that is going to get you in a better place. So you don't want to ever be caught under preparing. But the thing is, models use exponential growth curves, most of them. So if you get something off just a little bit, because it's an exponential growth curve, it will end up being a big difference in the end. And just a little bit off on an assumption can really throw the whole model. And I think that's the case that happens a lot and not well understood by the public.
I see. Okay, so that's a little bit on models. Now, if we go to the issue of tests, where do you think, particularly the U.S., is in regard to testing, and both the two kinds of tests that they're talking about now? So testing for the active presence of the virus of someone who's contagious, even if they're asymptomatic, and then testing for antibodies. And I've read that there's a fair amount of debate, it seems like, at least, about how good the second tests are, the testing for antibodies, of how many false positives and negatives there are in those tests. So I'm wondering what your current thoughts are about that.
So testing is really like the original sin of this pandemic. When we look back on it, that's what's going to be the lesson that everybody learns. And when you look at my early predictions, I thought the US would handle this so much better because I never thought we would bungle the testing as badly as it was. And I can say from personal experience, in March, it was horrible trying to get a test, how much bureaucracy and red tape there was, not just from the government, but also from hospitals that themselves made all this bureaucracy. Now in May, it's very easy to get a test. It's in most places in the country. There are probably some where it's not quite there. We're testing about 300,000 people in the country every day. There's not a special magic number we want to test, but we want to make sure that we're testing enough that we're not allowing chains of transmission to go undetected, and that we lose the ability to do case contact tracing. So I think it's much better now. And I think we're getting to a point now where we'll be able to even do home testing and do saliva testing. It's all getting to the place where it should have been very early on if we wouldn't have squandered 2 months preparing. And the issue with antibody testing is there are a whole bunch of different antibody tests on the market, and some of them are not very good. This is an area where the FDA basically said, we're just going to let it, they were basically burned by the entire, I think, the regular testing. So when it came to antibody testing, said, we just put whatever you want out there. And it's interesting because people have gotten so used to the FDA giving you a recommendation, no one knew what was good and what was bad because we don't have all those standard organizations that you might see in the absence of the FDA. So it took a while for them to catch up. And then they actually did, some of those groups did stand up and actually do some validation. And about a half dozen of them have pretty high specificity. The issue is that remember, this is the 7th human coronavirus, and 4 of those coronaviruses cause about 25% of our common colds. And there are cross-reactive antibody tests. So you want to make sure that you're getting one that has validation and looks to be specific. And I think we're getting there, and you can find those tests now. And I think increasingly that will be something people will get routinely done.
I see. Okay, we have about 5 minutes left, and there's 2 questions for sure that I want to get to. So one, you brought it up just now in terms of that this is a coronavirus. It's not the only one. The issue of vaccines. So how difficult a challenge is this to develop a vaccine? And you brought up that some of the common cold or coronaviruses, we don't have a vaccine for the common cold. So how big a challenge scientifically is this to get a vaccine? And then on what, if there's reason to think the challenges can be overcome, what time frame do you think we'd be looking at?
I don't think there's any biological barrier to making a coronavirus vaccine. There are coronavirus vaccines that veterinarians administer to cows right now and to avian species. So those are all animal species that can be vaccinated against coronavirus. So there shouldn't be a barrier to doing it. The fact was that because they were just common cold viruses and they only caused about 25% of our common colds, there wasn't a big push to make a vaccine for coronaviruses. That changed in 2003 when SARS appeared. But then SARS disappeared, and most companies that had started vaccines basically saw funding dry up and thought this was not a problem that we're going to deal with. And the same thing kind of happened with Middle East respiratory syndrome when it appeared in 2012. It wasn't something that really took off. It's still causing cases in the Arabian Peninsula, but it's never been a major public health threat. So there hadn't been a big push to make a vaccine. Although some companies had started to work on them, and they're trying to reanimate those for this coronavirus. What I think is happening now is a really rapid race to get coronavirus candidate vaccines into clinical trials, and it's going very, very fast, the fastest we've ever seen, using new technologies that probably weren't around even 10 years ago. And I do think that we're on a time frame that's going to be fast, but you have to remember that vaccine development is usually something that happens in years, not in months. And when you hear people say 12 to 18 months or by September, that's really, really optimistic, and everything would have to go perfect. And if I were betting, I don't think we would have one probably in probably till 2 years. And remember, we have to vaccinate the entire population or the entire world's population, and that's a major manufacturing problem. There are programs being put in place like Operation Warp Speed. Bill Gates has decided to build factories ahead of time so that people can have vaccines already going into productions before we figure out which one is the best one. All of that's going to help speed things, but I think we have to be prepared to deal with this virus without a vaccine for maybe a period of 2 years. And when the vaccine comes out, it's going to be tiered. It's going to be healthcare workers first, then probably the vulnerable populations, then the rest of the country. And if this happens, if the vaccine comes from one country, you can guarantee there's going to be an export restriction for the company, not allowing them to sell the vaccine outside of that country until the whole population has been vaccinated. And that actually happened in Australia with the 2009 H1N1 pandemic vaccine. They were not allowed to export it until the Australian population was vaccinated first.
I see. That's very interesting as well. So the other question I wanted to ask you is, because I know part of what you specialize in is being prepared, and you've said a little bit here, and I've seen other things you've said and written about how woefully unprepared we were, despite you and many other experts telling government officials that we need to be prepared. So what would it look like? So you've said one thing about testing, like that's a major, major failing here. What are the other elements that would go into a plan that would make us prepared that we're missing, and then thinking forward for whether reemergence of this in the fall or winter or a new infectious disease? What does it look like to be prepared?
Well, I think if you go back to 2009 and H1N1 and the flu pandemic there, I think that was a much better handled infectious disease emergency that we dealt with. And what we saw there was a quick recognition that wasn't politicized regarding what the virus meant and getting the country ready as soon as we actually knew that it was there. That didn't happen here. And it's not that we didn't have plans. These plans are there. And it's not that the CDC is the preeminent response organization in the world. There's people there that I'm literally in awe of, that know exactly what to do. It's just that this just got misfired from the very beginning and got labeled as a disease of China and not something that we were going to have to worry about, and nobody wanted to spook the stock market or whatever the other extraneous things were. But being prepared is having the ability to see what's going on in other countries, recognizing outbreaks that might come to the United States, and then quickly standing up a response, meaning deciding based on what it is. Do we have diagnostic testing? Do we have vaccines? Do we have antivirals? Are hospitals ready? Are our health departments able to deal with the cases that are going to come in for contact tracing? And it's not all rocket science. It's just something that's never really prioritized, because you go through these cycles of panic and neglect, from anthrax in 2001 or bird flu or H1N1 and Zika and Ebola. All of those things get people very nervous for a while, and everybody's very reactive to them and not proactive to them. So all these programs kind of wither away, and you have health departments and the CDC kind of distracted by things that are far from their core mission, because they're dealing with obesity, and they're dealing with air pollution, and they're dealing with children riding bicycles without helmets. All of these things are really things that they get distracted away from. And you look at the CDC as like an infectious disease organization, and the majority of their budget doesn't actually go to infectious disease causes. It goes to other things inside the CDC. So I think it's not a question of what it looks like. I think we have all the pieces. It's just they're not executed very well. And there are obviously missteps in terms of our strategic national stockpile, where we didn't have enough ventilators in the stockpile, where things weren't replenished after 2009 H1N1. And I think that all falls into the category of this panic neglect cycle, where people don't replenish things. But it's not. I think if you look at the costs that are needed to actually have an appropriate pandemic preparedness program, it's going to pale in comparison to what the economic costs are here. And I think that when you look at what a government's core mission is, to, when you're thinking about infectious disease or health, is really to protect individuals from becoming infected from contagious diseases in this manner, where there's a public health emergency, where people are being infected. And the government has that ability to respond. And actually the government has basically crowded out any other type of response. I do think that there was just a massive failure on that part. And I think it's because there was really a lot of politicization there. And it's still mind-boggling to me, some of the decisions that were made, because it's almost exactly the wrong things that you would do that actually occurred in terms of testing and putting a protocol where you could only test people from China, and they had to have lower respiratory tract infection, even though we knew there were mild cases that were there contagious. It was basically a recipe to get us where we were. And I don't know what the answer is, because the United States was ranked the most prepared nation against pandemics. And it was my think tank that was actually part of that ranking, the Global Health Security Index, and all of these types of ways of looking at it. So it really is something that we have to think about how this happened, because most of us thought we were much better prepared than we were. And we knew there would be difficulties, that hospitals might get stressed, but nobody, I think, thought that this would be bungled this badly.
I see. Let me ask one follow-up question to that then. So is that part of thinking that we were, even experts thinking we were more prepared than we actually seem to have been? You've brought up the issue of it being politicized. Is your view that some of the other countries that seem to have responded better, say Taiwan or South Korea, are two examples that are often brought up, is their public health in this episode, at least in this episode, does it seem less politicized? Because my impression is it's less. In some of the other countries, it's less politicized. It's not the president or vice president or the equivalent of them who are making all the pronouncements. And so it seems more like the public health department is more independent.
Yeah,
I'm curious what your view is.
Yeah, I think those countries take it very seriously. South Korea, for example, South Korea had a MERS outbreak in around 2013, 2014, which was really disastrous for that country. And they really made preparation a priority at that period of time and got to a point where they took this very seriously. The government people lost confidence in the government at that point. So they didn't want to repeat that. So they were very aggressive. And I think it's interesting you bring up Taiwan. Taiwan is one of the best examples of public health. But when you say that their vice president's not involved, their vice president is a PhD epidemiologist. So he's actually a different. So they actually have you actually want their vice president involved. And Taiwan is a great example because they got burned during SARS in 2003. And I was part of a team that evaluated Taiwan, because tragically they can't get evaluated by the WHO because they're not members of the WHO. So we went there. And the way they take infectious disease is something that's bad. The way Taiwan deals with the way that Taiwan deals with infectious disease emergencies is basically an exemplar for the entire world.
Okay, we're at our time, but thank you very much for your time. And is there any last thing you want to add? Something I didn't ask about, but maybe should have asked about? So any last point that you want to make?
I think that when people say that elections have consequences, I think this is an example of how elections have consequences, because when you look at this response, there are ways that there are things that were basically thrown out because of the politicization of this. And I don't think it's an accident that this type of test happened during this presidency. It's very surprising to me that it happened in my field to actually see exactly how important political leadership is.
So I think you can tell just how busy Amesh is by the fact that he was getting pinged even during this recording with Onkar. So just a reminder, that was a recording that was done 2 days ago. But now we are going to be joined by Dr. Adalja and by Onkar. So Amesh and Onkar, if you guys want to turn on your microphones and turn on your videos.
Yeah, I'm on.
Okay, there we go. So Amesh is in the same location. Onkar's looks slightly different, and you're wearing different clothes. But so we've got a ton of questions. We've got a bunch of hands raised. Onkar, since you're a very skilled Zoom moderator, I'm going to let you take over, but just let me know if you need me to help at all. I'm gonna turn off my video, but I'm here if you need me.
Okay, sounds good. Thanks, Keith, and thanks again, Amesh, for making time. I know you're on call, so. We appreciate it. And maybe we'll alternate. There's questions in the Q&A, and then there's people raising their hands. So let's alternate between some of the written questions and the audio questions. And there's been at least 3 about masks, and this was something that I didn't even ask about. We didn't have time in the interview. So the question, I think Sally asked just how effective are masks. Randy asked if both people are wearing masks and social distancing. So they're staying 6 feet apart. What is the chance of infection? And then Thomas asked, are there any side effects with wearing masks? And if you're inhaling CO2 and other toxins that you're trying to exhale, but the mask is preventing that. So are there any side effects, drawbacks from wearing masks? So those are 3 questions about masks.
Okay, so I'll start from the beginning. So there was a push early on for individuals in the public to wear masks. And most of us in the field said, no, that doesn't make sense. And this is the reason why. First of all, we were in a mask shortage, and we were really worried about our hospital workers being able to have personal protective equipment. And they were going to be the ones that were most exposed. We were worried about supply issues. Then there's been multiple studies looking at respiratory viruses in the community and having people wear masks and do good hygiene and seeing, do they actually benefit people to wear masks? And the answer was no, they weren't really protecting people from getting infected. So that was a standard thing that was going on for a while. And the question was, could you wear N95 masks, which are the more impermeable masks that we wear in the hospital? And those masks do cause you to breathe CO2. And I don't recommend individuals that are not in a hospital setting taking care of patients to wear an N95 mask, because it is very uncomfortable to wear, and you do get higher levels of blood carbon dioxide when you do wear them. The surgical mask, not so much. But that was where it stood, and the Surgeon General tweeted out, don't buy masks, don't buy masks. And then what happened over a period of time is a little bit of morphing, and there were some studies on asymptomatic transmission, so people who didn't have any symptoms at all spreading this virus. So this is still something very controversial. It initially came from a study of a choir in Washington where people were singing, and there was supposedly no one that had any symptoms. However, this is something that has really been studied in detail by the CDC, and the CDC just a couple of days ago started to release data on that choir, and it actually was a symptomatic person there. So that kind of throws the whole thing into question. We do know asymptomatic spread occurs, mostly in households, intimate partners, people that are very close together, which are not representative of the general population. So I'm somebody that has not been a major advocate of wearing masks by the general public, and I try myself not to wear them unless I'm actually forced to wear one, if I'm going into a store that is required to make you wear one. I obviously wear them when I'm taking care of patients because it's essential there. So I don't think that this is something that really has a lot of science behind it, and there are a lot of side effects. I just took a walk around Pittsburgh, and there's masks strewn around the ground everywhere. People throw them and litter them everywhere, which creates an infection control problem. People touch their face more when they're wearing a mask. They have these ridiculous rules in New York State where a 2-year-old has to wear a mask, and a 2-year-old is more likely to eat the mask than actually wear the mask, I suspect. So I don't think that there's much science between of the general public. However, this is very controversial, and most of us see this as a price we have to pay, and the fight's kind of gone on, kind of lost the fight trying to push the data on the science. So, but if you're 6 feet apart, you actually don't even need a mask because it doesn't transmit that way. So if 2 people are 6 feet apart, the virus cannot teleport that. It needs to have a mechanism, and those droplets don't travel that far in ordinary circumstances. So that's kind of where I stand on masks, and I'm definitely a contrarian, but there are more of me that are popping their heads up every once in a while. But it's a hard battle to fight because it's now taken as dogma.
Okay, thanks. Looking at some of the raised hands, Thomas Walker, do you want to ask your question? I can unmute you. Let me do that. Yeah, you should be unmuted now. Tom? Let me try one other. Yuri, let me try to unmute you.
Yes, can I be heard?
Yeah, we can hear you.
What should be the frequency of testing be? My understanding is that the purpose of the testing is, of course, if you're positive, you get isolated, or you should be isolated. So if I'm tested negative, how long should I sort of feel myself safe and others treat me as a safe person? It's not indefinite, right? Should it be once a month, or what's your thoughts on that?
This is something we're trying to work out and understand. And you're right. When you get a PCR test looking for acute infection, that's only one moment in time. It's telling you that you're not infected at this period. You could go outside and contract it right afterwards. Right now, we don't necessarily recommend that people without symptoms be tested outside of contact tracing investigations, outside of people getting screened for a surgical procedure, maybe that the hospital will require you to be tested, or some of the sports team people who have very close contact with each other. So this is something I don't think we have a good answer to, and I don't think the answer is to test everybody every month or every week, but it really is not the issue. I think the main the main thing is to being able to test people when they're symptomatic. And again, this goes back to this asymptomatic transmission issue, understanding what role it might play. And I do think there's a lot of questions about the circumstances and the context when that occurs, and they aren't necessarily going to be everyday life type of situations. So I think that there may be a little bit of overemphasis on asymptomatic transmission based on some studies that weren't quite, that a lot of people can't recall their symptoms very well, saying, oh, maybe I did have a mild headache that day, and they're not truly asymptomatic. And that's what's driving this idea. But I do think that the guidelines are going to probably not recommend asymptomatic testing outside of special enclosed populations like we mentioned.
Great. Okay, so let me now go back to a written one. There's been a few in this vein. Shoshana was one person who was asking about this. And it's what's the status of treatment for COVID-19, the antivirals, some of which are being used, and so on. So, as Keith said, you're a practicing physician as well, treating patients. So, what's your view of from the start to now? Has treatment improved?
So treatment has improved, and it's not just because of drugs that we use. It's also we're learning more about the disease and the pathophysiology of disease and the different stages people go through, and just being able to better manage the mechanical ventilator on some of these patients, because there is some odd lung physiology that's occurring that we haven't seen with many other infectious diseases. So that's one part of it. The other part is antivirals. And right now, there was no coronavirus antivirals prior to this pandemic. And we do now have an emergency use authorization for a drug called remdesivir. That's an IV drug. That's an antiviral that was initially developed for Ebola, but didn't do so well in the Ebola trials, but had some activity against coronaviruses, so they've used it. This isn't a knockout punch, to quote Dr. Fauci. It is something that really decreases the amount of time you're in the hospital. When you're a severe patient that's in the hospital, it gets you out about 3 to 4 days earlier, which is important when you're looking at hospital capacity. But it's not game-changing in that sense. Other drugs have not really panned out. People tried to repurpose hydroxychloroquine, which is a drug that's approved for autoimmune conditions. Most of the data that's coming out is not very favorable to this drug and the toxicity profile in coronavirus patients. I think that's an important distinction. People keep always saying, oh, this has been around for so long, it's safe. It's safe, but each person is a different substrate depending upon what disease you're treating it in. And when you're looking at someone with the coronavirus, they have unique physiology, and it does not seem to be beneficial, and there are some side effects there. There are other antivirals in clinical trials. We're doing convalescent plasma. That's the blood of recovered survivors, getting their antibodies and giving them to people. That looks promising. We're also trying to synthesize antibodies. But right now, we don't have anything close on the horizon that's kind of a Tamiflu equivalent. What would really be a game changer to me would be a drug that keeps people out of the hospital and decreases their contagiousness, something like Tamiflu does for influenza. We don't quite have that. There's one drug called favipiravir, which is approved in Japan, that may have that, but there's a lot of problems and questions about that drug. But that's the only real oral type of medication that we're seeing on the horizon. So we're still kind of in early days, but we're getting better at doing this, and hopefully that will bring down the mortality rate and also give people a little bit more confidence going forward in the era of the pandemic, that they have treatments that if they end up in the hospital.
Let me ask, because there's been questions so it's sort of in this vein, and I'm not sure, I mean, pass on this if you don't want to answer it, but particularly about Dr. Fauci, who I've heard you a number of times express your admiration for, that he's some kind of villain in this in this situation. And do you want to talk about that and your view of that?
Sure. Anthony Fauci is the opposite of a villain. He is actually a hero in this story. He is somebody that were not for him, who knows how badly this would have been managed. There's been many mistakes we talked about, but the fact that you've got basically a genius level infectious disease expert that's thinking about this and devoting his time to doing this when most people would be retired at his age. I do think that he is a pioneer in this field and has discovered so many different things about different infectious diseases that having him at the helm of this, having him part of the task force, has really been beneficial and has prevented some of the bad decisions from being made. And you have to remember, if you listen to what he says, he's talking as a public health expert. He's not talking about the economics of this. He's not talking about all that. He's asking you, he's been tasked with one thing, to try and minimize the impact of the damage from coronavirus 19. And I think he's doing the best that he can do. And I think he's in a constrained position based on the politics of this, but to think that he is a villain or that he's trying to be some kind of dictator is the wrong way to think about this. I think he is a subject matter expert that's doing the best he can, trying to solve what is really an insoluble problem. We've been left with horrible choices here of opening the economic shutdowns on the one hand and people dying from this disease on the other. And I think that there's not any kind of black or white answer here. It's all a lot of gray. And I think having somebody like him at the helm with the other experts that are there is really, really to our benefit. And I think that attacking him is really not the way to go. It's actually the politicians that have constrained this response from the beginning and left all of us that are in the infectious disease field with a really poor situation to try and fix. And there's not going to be a good way out of this. This is going to be an enormous cost no matter what we do.
Let me now go back to a written question. There were a couple of in this vein as well, one from Gavin about the issue of antibodies. You talked a little bit about developing serums from people's blood, but the issue of, can you get COVID-19 again? Can you be reinfected and get the disease again? Or could you be reinfected and you might not get it, but you could be a transmitter again of the disease? What is your thinking from the evidence now about that?
So with other coronaviruses, we know that in general with infectious diseases, once you recover and once you clear the infection, you usually have a period where you're not susceptible to reinfection. That period may last for a lifetime in certain diseases like measles, for example, or it might be a year or so with other infections. With other coronaviruses, we know that people can get reinfected experimentally. That means in a lab, somebody actually injecting the virus into your nose. That's not really necessarily real life, but those people who get infected have mild symptoms. With this coronavirus, most of us assume that there is going to be a period of time when you cannot get infected, and that will be probably something we have to actually do a natural history study to see exactly how long that period lasts. And this is something that would be reflected in antibody testing, but antibodies aren't the whole thing with the immune system. Remember, there are multiple arms of the immune system, and there is something called cell-mediated immunity that may also play a role. So I do think that once you recover, you're at least for a year going to be protected from reinfection.
Hi, thank you both for an excellent presentation. Two questions. One, can you speak to the logic and the legitimacy from your point of view and the efficacy of lockdowns? I mean, what context do you think they make any sense? And the second question is personal. My wife is 7 months pregnant and a nurse, and do you have any special insight into the vulnerability of pregnancy if you're immunocompromised, or any advice in that respect?
Sure. So for the first one, with lockdowns, and I would draw a distinction between lockdowns and shutdowns, because even our shutdowns in the United States, even as horrible as they are, and every one of us has suffered through them, they were not like Wuhan style. They were still a lot of, they were leaky, I guess, because they were designed mostly to basically have room in hospitals, basically to make sure hospital capacity was preserved. That's why those lockdowns were initiated. And they were done in order to, they were done. We kind of got left with lockdowns, and they're a very blunt tool for infectious disease. Nobody wants to use lockdowns. But if you think about what happened in January and February and most of March, that we weren't doing testing, we weren't testing individuals that had mild symptoms, we weren't doing that much contact tracing. We were very focused on travelers only from China, when now we know that this was actually in France around Christmas time. That really constrained our ability. And what ended up happening is everybody all of a sudden realized that we have a huge problem of cases. We don't know who's infected and who's not infected because we didn't have any tests. And we're worried about New York City going into crisis because their hospitals are overwhelmed, and other hotspots boiling in New Orleans and Detroit and Chicago. So that governors got very scared, and that was the only blunt tool they had. And that's not what we would have been in our playbook. Our playbook would have been testing, tracing, isolating in the very beginning part of this outbreak. Back in January, when I was saying this is already here, stop trying to focus on China and Air Force-based quarantines, that we really have to start getting our hospitals ready and get our diagnostic testing scaled up, get the private industry engaged early. That's what we should have done. But lockdowns do work as a blunt tool. They don't necessarily need to be used. They didn't necessarily need to be used everywhere. They didn't need to be as broad as they were. But I don't think if you would have done something in New York City, I don't think you could have avoided doing anything in New York City because of how badly it was hit. They would have been in a disaster zone in their hospitals. And I think that you can't underestimate how crucial the healthcare system is when you think about this type of a decision. So the efficacy is limited. It's the last resort you want to do. And I think we should blame the politicians for the fact that we had to do the lockdowns, because they squandered 2 months of preparations. And the lockdowns did achieve their purpose. Their purpose was not to decrease the number of cases, not to decrease the number of deaths. It was to flatten the curve so that we didn't exceed hospital capacity. In that sense, they were effective, and that's why you're seeing them peeled back, because we actually did not overwhelm our hospital capacity.
And the pregnancy part?
Yeah.
Oh, sorry, the pregnancy part. So right now, so with many infectious diseases, pregnant women do fare worse. For example, influenza, pregnant women are overrepresented among those that are hospitalized, and that's why pregnant women all should be getting vaccinated against influenza. Right now, if there are any pregnant women listening, they should be going to get vaccinated for flu, especially this season when we have both of these viruses to contend with. But with coronavirus, we haven't seen very bad outcomes in pregnant women, and that's interesting, and nobody quite understands why. There hasn't been a lot of data. There's only been one case report where there was a placental insufficiency case that occurred where the placenta got infected, and that led to a miscarriage, but that seems to be very rare. So right now we think that pregnant women are doing fine, and some of my friends are pregnant healthcare workers, just like your wife is, and they're working away. And I think the data does seem reassuring when it comes to pregnant women, at least so far.
We don't have that much time left, so let me take some of the written questions, which are sort of in that vein of thinking about the risk factors, but putting it a little more widely. So you talked about in the interview about people have to start learning to live with this virus. So in living with it, what are things that people should be doing and be on the lookout for? So for instance, one of the questions was, if going back to work, or if you're an employer and you're having employees come back to work, what can you do to help reduce the spread at work? Is getting on an airplane? Will that be safe? So in terms of people thinking of going back in the world, how do you think about that general issue and then some of those specifics?
No activity is going to be risk-free. That's an important thing. And it's not going to be, I keep getting media questions about, can you do this, can you do that? And I can't be overly prescriptive because it really is going to depend on the individual, what their risk tolerance is, what risk factors they may have for severe disease, and they're going to have to make a choice. There's going to be ways to do things safer. Obviously, if you're 10 feet or 6 feet away from everybody all the time, you're not going to necessarily have a mechanism of getting it. If you're meticulous about washing your hands, if you try to avoid crowded situations, if instead of flying somewhere, you drive somewhere instead, there's things that people can do. And I would especially recommend that people that are in a high-risk categories think about modifying their life. This is going to be with us until we have a vaccine. That might be 2 years. So if you are in a high-risk group, you're going to have to think about what your life is going to be like dealing with a virus that could put you in the hospital and be very severe, especially if you're above 60, 70 years of age. So I do think that there's going to be modifications in our society to try to make it easier for individuals to go about things. But it's not something that's going to be easy, and it's not going to be one size fits all. And it's going to be something that we haven't dealt with for a long period of time, and everyone's going to approach it differently. So I hope all of this kind of the shaming that goes on when people do things that aren't necessarily what other people would do goes away. Because really after the hospital capacity problem is solved, then it really does boil down to individual choice and what you want to do. And I think that's something that's very hard for many people in the media and in the world to swallow, because they're so used to proscriptive guidance. And I don't think that we can give it. I think it's really going to be an individual choice, which is what it should have been, what it should be.
Keith, we have a minute left. Is that right?
Amish, I know your schedule is extremely busy, but if you're able to stay on for a few minutes longer, can we keep you and go for a little bit longer?
Yeah, we can. I'm good. I didn't get any pages during this time, so I don't have to answer anything.
Okay, then let's go for.
We have 60 questions, I think, in the Q&A, so I haven't had a chance to read them all now. I've read a number of them, but if you've noticed anyone.
Well, a lot of people are asking about which kind of antibody test they should get. Is that one that's come up so far? I think
I answered that in the other part, but I can ask again if you want.
Yeah, go ahead.
So there's a lot of antibody tests out there that have a lot of false positives. So right now, if I were to give brand names, I don't want to give too many brand names, but I would say that if you use Quest or LabCorp, which are the national chains, those tests are very good, high specificity. Also, there is one by Roche, the pharmaceutical and diagnostic company that has one. But I think Quest and LabCorp are the most convenient. You can go on to their websites without a doctor's appointment and without a doctor's prescription and set up an appointment for blood draw.
Okay.
I think there's been a few questions about the hospital capacity and how much regulations and government controls interfered with hospitals being able to gear up and to meet the surge in demand.
This is a complicated question. So there is this issue where when you're building a hospital in a town, that you have to present what's called a certificate of need. And the state has to decide, yes, we need more hospital beds here. No, we don't. And often that, not only is it the government, it also is a lot of cronyism where another hospital chain will block the other hospital from doing that. And that happens like every day in Pittsburgh. So that is something that's really become a problem. The other issue is that hospitals themselves don't want to have beds open because it's basically like a hotel. They want to make sure that they're at capacity all the time. And they do switch their inventory to just-in-time management, just like a company does, so that they don't have that many supplies on hand more than like a month, and they continue to get these type of really quick supplies. And that's kind of a general change that's happened. So I think it's both the fact that we have the government constrains the ability to make new hospitals, and then the other fact is that the hospitals themselves have tried to become more streamlined in their operations, because there's a very small margin in a hospital. Most hospitals are not in the black; they're all in the red. And I think that probably is also a function of the fact that Medicare reimbursements are the major source of revenue for many hospitals, and that's going down in general over time has not been that lucrative. So I do think you can't separate the hospital capacity problem from the fact that we kind of live in a mixed half socialized medicine, half free market medicine type of environment. And you've seen places like Canada, which are fully socialized, not have this problem because the hospital, they build extra capacity for some reason. So I think it's really hard. That's one of the challenges, is you don't know actually what's caused by what, because it's so mixed that it's hard to disentangle things. And you have seen countries that have universal healthcare not have the hospital capacity problem we did. And I think in many ways this mixed system is actually in some senses worse because of that. And it's controversial to say, but I do think that the socialized part of this makes the other non-socialized part, it actually influences that as well.
We could take a live question. Farhana, would you like to, hang on a minute. Oh, can you
want me to do it?
Yeah, something's wrong with my settings.
It's actually not letting me do it anymore either. I don't know what's happening.
Okay. Well, then why don't we go to one of the written questions? Do you have another one lined up there, Onkar?
There's been a few asking about early on in the pandemic and the role of China in this. So I think there's evidence that they've covered it up. They went after some doctors who were talking about this. How much of an impact has that had, do you think? So if this happened in a country that was much more transparent, what do you think would have happened at the start of the novel virus appearing?
So it's hard, because in the very beginning, a lot of us said that China was being very transparent because they actually notified the WHO on December 31. And this is something very different than what they did during SARS, where they basically uncovered the entire outbreak up and it was leaked through an email listserv. So that part, people were giving them praise, but now we find after the fact that they were stifling the free speech of doctors, imprisoning a doctor that was heroically telling people about it. So I think that when you look at China overall, I do think that they get very black marks for how they handled this, because they expelled journalists from the New York Times, the Washington Post, and the Wall Street Journal. They definitely did not want the narrative other than theirs to be out there. And I think it's important to know that I think that they may not have known so much about this disease prior to November or December. They might have seen some trickle of it in November and December, but not enough, I think, that they noticed it, because I think there's enough Western influence at that point that we would have heard about it. We heard about it pretty quickly when it happened, but I think that there is a chilling effect, and people are not going to necessarily report things up if they think it's odd or it's going to get them in trouble. And much of this is done at the local Communist Party level, not at the central level. It's usually the people in Wuhan and Hubei province that were the ones exerting this influence, and I think they're going to be probably punished pretty harshly for it. But that's the whole culture there creates this chilling, this chilling effect there, and I think. And it's interesting because I had to do a lot of media on Chinese television. I stopped going on because I realized it was propaganda based on the questions I was getting asked. And it was very clear that they were trying to switch the narrative back on the United States. So it is a highly propagandized environment there. And I would not be, and I think it's always going to be a problem with infectious disease emergencies, because they tend to be a hotspot, and they tend to have this type of culture where they don't want to get in trouble, so they don't tell anybody because they're too scared, and then it ends up bubbling up, just like Chernobyl, basically, every time with these infectious disease emergencies.
Amesh, we've been getting a lot of comments in the chat. The audience here is really appreciative of your time, and so I just wanted to report that to you. People asked me to extend their gratitude for your time and your expertise. The question from Farhana was, what has been an important lesson for you from this experience? What are you taking away from this whole situation?
So one of them is that even if something looks good on paper, like the United States preparedness, that the execution and the politicians that are in charge really play a major role. I think that it's very strange to see a political fiasco occur in your own field. That's been really eye-opening to me. And then so I think that I think I'm going to be a little bit more humbled by how badly things can go. Even if I might know all the right answers or think I know all the right answers, there may be extraneous things that happen, like diagnostic testing that none of us could have think would have happened, or whatever happened in northern Italy that really changed people's views. I'm also much more cognizant of conspiracy theories. We had a conspiracy theory question just a minute ago, but I think that that's been something I've never thought would get this bad, where people think that 5G towers can transmit coronavirus, or that Bill Gates wants to put a microchip into your body with the vaccine. I mean, it's so strange that heroes like Dr. Fauci and Bill Gates get attacked over a coronavirus. But so that part of it, I think, has been eye-opening to me, just how different the culture is in terms of how to respond to this. Think of the culture during polio. Were people attacking Jonas Salk? I just didn't appreciate how much our culture is denigrated, that the people that are trying to solve this problem are not heralded the way Dr. Salk was.
Okay, let's try. I think our functionality is working here. So Andrew Whalen, do you want to unmute yourself and ask your question? Are you there? Andrew, it looks like you're unmuted. Can you be heard?
Yeah,
okay,
I think I tried him before too, and it didn't.
3 strikes here. Okay, well, let's see. We could take one more question from the Q&A module.
I think I saw the Whalen question in the chat, though. If he really wants, maybe I didn't. So, okay, go ahead. I can take whatever.
Onkar, do you have a?
Let's see what could be a good last question. Well, let me ask a question. So what do you think going forward? What are steps that could be implemented that, so if we have further outbreaks, and so that the response is better? It still might not be perfect, but the response is better than what it was. So what do you think are immediate things that, if they were implemented, would help a lot?
I think we have to get better at surveillance of infectious diseases. How many times have you went to the doctor and been told you just have a virus and not had a specific diagnosis? And the same is true in the hospital. We have patients. Just now, I was taking care of patients with pneumonia, and I don't know what caused the pneumonia, trying to get those getting diagnostic testing better. So we have much more situational awareness of what's going on. That's something we can do every day with medicine, and trying to get better at just knowing what's out there. That's one thing. The other thing is that we do have all these public health agencies that are massive experts. So if you want to do this field, places like the CDC are the only place you can go to do it. I think we need to empower the CDC to work on their core mission and not be dealing with all these extraneous political things that become the topic du jour that the CDC is then tasked to work on. I think the CDC, it used to be called the Communicable Disease Center. That's what it was built for. And I think that's one of the problems, is that you have health agencies that are not on their core mission anymore, and then they're always slow to respond because they have to pull resources from other places. So I think that's one other thing that can happen. And I just think that from a national political level, the pandemic preparedness and infectious disease emergencies are always going to be threats. We've had threats during basically the last 3 administrations without multiple threats. And I think that this is something that you really have to take seriously if you're thinking about what are the national security threats that you may face. And it's bioterrorism, it's pandemics, all of that stuff needs to be taken seriously at the top level. It should be something that people think about. And I talked about that cycle of panic and neglect. We have to break out of that. And the only way we're going to do that is by really making this a priority to politicians, that you have some understanding of what could happen if you do this, because I think everybody's been harmed by the lack of the preparedness now. And if you can think about how paltry the sum is to actually fix these problems and to get it better, it's going to be so much less if you look at what we're going to suffer from this pandemic and the economic shutdowns.
Thanks for watching. To help keep content like this free, consider supporting ARI by becoming a member at aynrand.org/membership.